So thank you to everyone for the opportunity to present an update on some of our trials funded by the NIHR and conducted at Imperial College London within the section of vascular surgery. I'm Rebecca, one of the trial managers supporting the project management of these RCTs. And I'd also like to thank Thrombosis UK for supporting our patient and public involvement and always promoting our studies. So in this talk, I'll just provide a bit of background on the studies before presenting the three trials funded by the NIHR, and they're all RCTs looking at the benefit of graduated compression stockings in surgical patients. So as I'm sure you're all aware, hospitalized patients are at increased risk of VTE, and VTE in these patients is a leading cause of preventable death. Hospital-acquired thrombosis is defined as any VTE occurring up to 90 days after hospitalization and accounts for around 2/3 of all VTE, and it leads to significant health and societal burdens. There's a well-established and long history to the National VTE Prevention Programme, first highlighting in 2005 in a select committee report that there are around 25,000 preventable deaths from VTE each year. And there wasn't a systematic approach to identifying or treating these patients at risk of VTE in hospitals. In subsequent years, NICE published guidelines for the risk assessment of all surgical patients. 2008 saw the development of the VTE exemplar centres and the national rollout strategy focusing on education, audit and quality control. Guidelines were developed for all hospital patients, and the cornerstone of the programme was the introduction of the mandatory documented risk assessment for VTE, first included as a sequin, but I think it's now under the national quality requirement administered via NHS England Digital. So VTE is common following major surgical procedures. It accounts for around 25% of VTE in the community, even with current prophylaxis strategies. Post-op VTE risk is variable by the type of procedure, higher risk in orthopedic surgery, neurosurgery, vascular surgery, and some others. And it often occurs after hospital discharge. So the key for surgery is trying to balance VTE risk with bleeding risk before providing any intervention for a patient. A risk assessment tool should be administered to all inpatients to guide any decisions around thromboprophylaxis. And there are two major modalities for the prevention of post-operative VTE: pharmacological prophylaxis in the form of anticoagulants or antiplatelet agents, and mechanical prophylaxis, so graduated compression stockings, intermittent pneumatic compression devices, and IVC filters. NICE recommends that treatment with compression should be considered for most surgical patients in addition to the pharmacological thromboprophylaxis. However, the evidence base for graduated compression stockings is poor. A previous Cochrane review reported a benefit for the use of stockings, but only included small data trials, and many of these trials were funded by stocking manufacturers. This review also excluded two larger trials from stroke and orthopedic patients, neither of which supported the use of stockings. The CLOTS-1 trial showed a number of associated adverse events with compression, and two further systematic reviews from Prof. Davies' group, one in 2023, which showed no significant differences in the rates of DVT, PE, and VT-related mortality between the pharmacological prophylaxis group versus the addition of a compression stocking. So the GAPS trial was the first large-scale RCT in this series of trials, which commenced in 2016 with the aim to determine whether low-dose, low-molecular weight heparin is non-inferior to standard of care, so a compression stocking and low molecular weight heparin for the prevention of VTE in surgical patients who were all risk assessed as being at moderate or high risk for VTE. The results were published in 2020. A total of 1,888 participants were randomized 1-to-1 between the intervention and the control arm. And the study showed in patients at moderate or high risk that the intervention arm, so the drugs alone, is non-inferior to the drugs and stockings. Gaps excluded the lowest and highest risk patients, which were then further included in the PETS and GRACE studies, respectively. So the PETS trial, another NIHR-funded trial, was the next in the series of RCTs. The primary objective was to evaluate the potential benefit of stockings in the prevention of VTE in patients undergoing short-stay surgical procedures. So those assessed as being at low risk for VTE. Whereas GAPS was a non-inferiority design, due to its large sample size, PETS was a cluster trial whereby the sites themselves were randomized to issue stockings or not issue stockings, and patients were eligible to join if they scored 0 on the Department of Health risk assessment tool. So these are low-risk patients, the lowest risk. There were a number of secondary objectives to compare mortality rates, to compare quality of life between the two arms, to compare adverse events, to identify adverse events associated with wearing the stockings, and the plans to perform a cost-effectiveness analysis as well. The trial opened to recruitment in October 2020. Although recruitment was under target, you can sort of see between the two deviating lines there, recruitment did improve as the trial progressed. Following review by the NIHR last year, it was decided that the trial had answered the originally commissioned question, and the decision was made to close to recruitment. A total of just over 11,000 participants were randomized into the PETS study. And at the time of closure, the team were invited by the NIHR to submit a proposal to conduct additional work during the close down phase. There were challenges to recruitment, as you can imagine. Around 45,000 patients were screened as ineligible to participate. The most common reason, due to the fact that patients were risk assessed as moderate or high risk on the risk assessment tool. Around 30% of patients were screened out due to reasons coded as other, which were to do with the some issues to do with the completion of the VTE tool, and around 9% of patients refused consent. So partway through the trial, the team launched a site feedback survey asking all participating sites to report on their experience of recruiting to PETS. The majority of sites reported issues with the patient population, with the majority screened out due to scoring, having a score, so 1 or more on the risk assessment tool. And almost half of the sites reported issues with inaccurate completion of the risk assessment tool. And a third of sites reported that the risk assessment actually wasn't completed at all. Around a quarter of sites reported issues with enforcement of the treatment allocation, and many clinicians were actually reluctant to deviate from their standard of care, which was typically to provide stockings. And we found that with the other trials as well. So the analysis is currently underway, so I can't share the findings just yet. But in terms of some observations, there was an imbalance in recruitment, so 64% to stocking sites and 36% to no stockings. There were some differences between the baseline characteristics between the two arms, which we were informed of by the DMC. We don't know as yet where these differences lie, as we remain blinded. But taken together, it suggests that there were issues with a lack of equipoise and maybe clinicians' perceptions regarding the acceptability of either providing or withholding stockings. We think there might have been potential selection bias, with clinicians cherry picking patients they perceive to be at the very lowest risk, with the difference between the baseline characteristics. And issues with the delivery of the trial itself, with the treatment allocation in the control arm being difficult to enforce. Follow-up rates were good, with 86% at 7-day follow-up and 98% at 90-day follow-up. In order to better understand the results of the study and the issues with the lack of equipoise, my colleague is currently conducting some additional work, some of this additional work during the close down phase, with some interviews with clinicians and the study delivery teams to explore attitudes towards stockings and VT prevention in general. along with experiences of recruiting to an RCT. And we've also launched a questionnaire to help explore these attitudes, and we plan to prevent some vignettes to explore the selection bias. And the team are also hoping to conduct a case note review in which data will be extracted from patient records to better understand the characteristics of those who did and didn't participate in the trial. So I don't know if anyone on in this meeting now took part in PETS, but if you did, and you were involved in the management of surgical patients at a PETS recruiting site, then please consider completing this short survey, which you can access via the QR code here, or just get in touch. We can circulate it later. The analysis is underway and the results are expected later this year or early 2026. If you have any questions or request any further information, my colleague Sarah Peerbooks is available on this email address. So GRACE is the last in the series of these Stockings RCTs. The aim is to evaluate the potential benefit of graduated compression stockings in addition to an extended duration pharmacological thromboprophylaxis post-discharge for elective surgical patients who are at highest risk of VTE. Patients are recruited from specialties including bariatrics, major orthopedic surgeries, gynae procedures, and other procedures where patients will be expected to go home with a prolonged course of anticoagulation. This is another non-inferiority study. Our sample size is 8,608 participants, which will give us 90% power at a one-sided 2.5% significance level to detect a non-inferiority margin of 2%, with the assumption that we will see an 8% rate of DVT. Patients are randomized 1-to-1, again, between drugs and stockings or just drugs alone. So as with the other studies, this is fairly pragmatic. We don't specify any brand or type of anticoagulation or compression stockings that sites should use. Stockings can be above knee, below knee, whatever is usually prescribed. And the extended duration thromboprophylaxis is any low molecular weight heparins, any DOACs, or any antiplatelet at a prophylactic dose for the prevention of VTE post-discharge, and we just ask that it is for a minimum of 5 days. So once patients are assessed for eligibility at their local hospital prior to surgery and completing their consent, they are then computer randomized to interventional control, and follow-up is conducted centrally at Imperial College London. Patients can be contacted remotely, so they can specify whether they prefer to be contacted via telephone. They can receive email, follow-up links, or SMS as well. And they're followed up at 7 days, between 21 to 35 days, and at 90 days post-surgery. We ask them a series of short questions, whether they've had a VTE, any adverse events associated with the stockings or the drugs, and self-reported adherence to the stockings and drugs as well. Their local site arrange patients to undergo a full lower limb bilateral duplex scan at 21 to 35 days post-surgery to identify any asymptomatic DVT. We currently have 42 actively recruiting sites across the UK. We are still enrolling new centres in case anyone is interested in joining the study. We'd be very keen to have you on board. We're also registered under the NIHR Associate PI scheme, so it's a great way for any trainees to gain any principal investigator experience, and they'll get formal recognition of engagement with portfolio studies. And it's also endorsed by the Royal Colleges. So you can see here just a diagram of our project management plan. GRACE study started in Jan 2024, and we're currently in month 22 of recruitment. We are slightly behind target. Obviously, conducting such large RCTs in the NHS, I think we've probably encountered most of the problems that you can. So huge delays in R&D and gaining local approvals. national issues to do with backlogs for conducting the bilateral scan, the research scan, which is also a reason why lots of sites unfortunately can't participate. And it's difficult to ask sites to prioritise these research scans. Doctor strikes obviously have an impact on cancellations and surgical lists being cancelled or delayed. There's often a high staff turnover in research, and it can be also a hard sell to patients to potentially be randomised to a study where an intervention is removed. We thank our 42 study centres for getting us this far, and they do a lot of work going around individually engaging with each surgeon to screen and recruit their lists and make sure that they stick to their treatment allocation once the patients have been randomised. Our planned analysis and dissemination is scheduled for the end of March 2027, although this may be delayed if we are given an extension. So stay in touch to watch this space on the results. So just in conclusion, this is our PI, Prof. Davies. Think VTE, evidence, guidelines, patients prophylaxis, and any risk versus benefit. And here are our contact details if you have any questions. So thank you very much.